Hello, MedSurg students. This is your nervous system A&P and assessment lecture. I'm just going to go over a few things in the A&P that I think might help you. First, I'm going to talk about Broca's versus Wernicke's area. You must know these areas. So Broca's area is in the frontal lobe near the motor center. And if somebody has damage in this area, usually on the left side of the brain for both types, um, they are going to be non-fluent. In other words, they have expressive aphasia. So their speech is either slow or broken, or maybe they're aphasic altogether. They can't talk at all. Okay. Wernicke's is in the temporal lobe, and they cannot process information that you're giving them. Their speech is fluent and normal, and they sound really well, but they're going to talk like in word salad. Okay. Um, and then this, we talked about the supratentorium and infratentorial areas. So there's the tentorium in between the cerebrum and the cerebellum. So remember, if somebody has a craniotomy or a problem in their supratentorial area, the cerebrum, the head of bed needs to be 30 to 45. If they have surgery infratentorial, the head of bed needs to be flat or no more than 10. Okay, and they get turned side to side. All right, so I'm going to skip down a little bit. I just want to point out that your brain needs oxygen and sugar to function. That's why oftentimes when there's a change in the LOC, you need to check the O2 sat and you need to check the blood sugar, because those are two really easy fixes. And people can present like they're having a stroke by having hypoxia or like low blood sugar. So that's just a little tip. Our brain is well protected with our skull. Okay, I'm going to talk about intracranial pressure. The normal intracranial pressure is 10 to 15 millimeters of mercury. What comprises intracranial pressure is the volume of brain tissue, plus the cerebral spinal fluid, plus the cerebral blood flow. That's why when we worry that somebody has increased intracranial pressure, we want the head of the bed up so the cerebral blood flow can flow down. We also want the neck in a neutral position so the veins can drain the blood from the head, okay? And with the volume of brain tissue, when somebody has a swelling brain, we worry that the intracranial pressure is going to get really high, and we'll talk about that later. All right, let's talk about some cranial nerves. Some are important for you to know. Okay, so the third cranial nerve, the fourth cranial nerve, and the sixth. Move your eyes. So 3, 4, and 6 make my eyes do tricks, okay? 2 and 3 are involved in pupil response, but like when we're doing a neuro assessment on somebody that's had, like, say, a brain bleed or a TBI, we're looking for a dilated pupil, which means that cranial nerve 3 has probably been compromised or occluded. So if the brain herniates and puts pressure on cranial nerve 3, you're going to have that blown, dilated pupil. All right. Some other important cranial nerves are 9 and 10 because they're in charge of the gag reflex. And then 12 is for tongue movement. So that's the hypoglossal. And that helps us have speech, also keep our tongue midline. That's one of the things you do when you're doing a neuro assessment, have the patient stick their tongue out at you. All right, health promotion. How do you prevent getting a head injury or increase intracranial pressure? Wear helmets. Don't drink and drive. Do not dive into water of unknown depth. I've taken care of several people with spinal cord injuries because they did that. Use seatbelts, car seats. If you're going to be using pesticides, make sure you wear long pants and long sleeves and a mask. Pesticides have been linked to Parkinson's disease. You want to control hypertension to prevent stroke, and don't use cocaine or methamphetamine. Okay. because that can raise your blood pressure very high. Now, when we're collecting data on somebody that's had some type of neurological condition and we're worried about increased intracranial pressure, all right, we have to look at their vital signs. An increased temperature you want to try to take care of because that's going to increase intracranial pressure more. Having increased intracranial pressure can also increase your temperature. The first sign of increased intracranial pressure is going to be a change in the LOC, but the blood pressure pulse pressure may widen. So the pulse pressure is the difference between the systolic and diastolic pressure. So if you look here, a wide pulse pressure equals increased intracranial pressure. And this is a late sign, okay? This is a circling the drain late sign, okay? If they have a narrow pulse pressure, that's shock. You calculate the blood pressure by subtracting the diastolic from the systolic. So if you look at this blood pressure here, 126 over 78, I take 126 and I subtract 78 and my pulse pressure is 48. A normal pulse pressure is like 40 to 60. With 136 over 64, I subtract 64 from 136 and I get 72. So this patient, if they had these two blood pressures back to back, you probably wouldn't bat your eye, right? But look at how much the pulse pressure has changed. So you need to keep your eye on that in patients with neurological conditions, especially if it comes with bradycardia, changes in respiratory pattern. That's called Cushing's triad. So Cushing's triad is a late sign of increased intracranial pressure. It means the patient's going to develop bradycardia, changes in their respiratory pattern, and a widened pulse pressure. So be looking for that. When we're assessing the LOC and mental function, we want to make sure there's not a change in the LOC. They're alert and oriented. That's what we all hope for, right? The Glasgow Coma Scale is a good tool. The total score from the Glasgow Coma Scale that you can obtain is 15. The least score, or the lowest score, I should say, of the Glasgow Coma Scale is 3. So the range is from 3 to 15. Less than 8, it's time to intubate. A Glasgow Coma Scale of 3 or less, that means your patient is comatose. A decrease of 2 or more, you need to report that. 2 points or more, you need to report it. Now, an increase in Glasgow Coma Scale is good because 15 is the highest, right? So it's good if it goes higher. Okay, so a mild TBI is going to be a Glasgow Coma Scale from 13 to 15. Moderate is 9 to 12, and severe is 8 or less. Okay? Okay, now posturing, you need to understand posturing. There's flexion and there's extension, and they are located in on the Glasgow Coma Scale under motor response. So if you notice here, flexion gets you 3 points, but abnormal extension gets you 2 points, okay? So all that to say is that decorticate is better than decerebrate. Neither one is really good, but it just means with decorticate, see the flexion, they're trying to protect their cord, is how we say, to remind us that it's not as bad as extension, because in decerebrate posturing, this means it's in the brainstem. I just think of it like this. If somebody's flexing, they're still trying. If somebody's extending, it's like they're giving up. That's how I remember which one is better to get. So that's important to know. You're going to look for posturing. In mental function, you want to know if they're alert and oriented. Do they follow commands? Are they making good choices? Are they saying the right things? And make sure facial features are symmetrical. All right, pupils and extraocular movements. Remember, it's 3, 4, and 6. Your pupil, check the pupil reaction to light. That's cranial nerve 3. It should be 2 millimeters. That's the normal size. And you want to know if your patient has nystagmus. It's because it's normal on extreme lateral gaze, but really they shouldn't have nystagmus. So nystagmus means involuntary eye movements. It can occur in conditions such as multiple sclerosis, which we talk about this for this unit, phenytonin, people on phenytonin, and it could mean they have a brain lesion. And it's a safety issue because look at how their eyes are moving, involuntary eye movements. Six cardinal fields of gaze. You can ask your clinical instructor to show you how to do that, but it's to check to make sure all the cranial nerves are moving the eyes, 3, 4, and 6. Okay. So a neuromuscular exam also would contain the client's ability to follow verbal command. You ask them to push the palm of the hands with their feet, and they can extend their arms and press down on each arm one at a time if you want to test their strength. And then look for pronate or drift. Typically, they'll do this if they think somebody is coming in with a stroke, right? So hold your arms up like you're holding a pizza, and then pronate or drift. One of them is going to fall down. Okay, so it's going to drift down. All right, the Romberg test. This is a test of equilibrium. You're going to tell the patient to stand with their feet together and arms out to the side. Test with the arms open and closed, swaying. Okay, so that means their balance is off. Is a positive Romberg, and this could happen due to inner ear or cerebellum conditions. So problems with cranial nerve 8 also. All right, LP, lumbar puncture. We went over this in class. Positioning is important. You have to get a consent and do a timeout. So cannonball positioning. It's not done if they have increased intracranial pressure. They have to lie flat for several hours after, and that's to prevent a spinal headache, which is really excruciating. And you want to push fluids so you are putting back fluid into the body that you took out. All right, cerebral spinal fluid and bacterial meningitis, because oftentimes they do this in meningitis, and you'll learn about this in peds too. It's going to be cloudy and have low glucose because bacteria love glucose. And so they're going to eat it out of your cerebral spinal fluid. Viral meningitis has clear spinal fluid, and I'm going to talk about the other conditions that we do a spinal tap on when I get to them. Cerebral angiography. The word angio means blood vessel, and here it means arterial. Okay, so this test is done to check the blood flow to and within the brain. So it's looking for vasospasms. It's looking for areas of occlusion, like areas of ischemia. So somebody had maybe a ischemic stroke, or somebody had a TIA, or somebody has an aneurysm and they're checking for vasospasms. So what they do is it's iodine based, and you need to warn the patient about a metallic taste in their mouth and a warm feeling when they put the dye in. You also need to check the BUN and creatinine. We talked about this in class, and hold the metformin and make sure they have a good urine output and they're getting fluids. The head is secured before the test, and they put the catheter in either the groin or the neck. So after the procedure, if it's in the groin especially, they're going to have to lay flat and not bend their knee, and you're going to check for bleeding after, because they go in through an artery, so they may end up bleeding. EEC. So this is the electroencephalography. Okay, so this is done usually on people that have had seizures. It can also be used in times to detect brain death. Okay, with the EEC, there are a lot of nursing implications, like the night before you're going to wash the patient's hair, or have the patient wash their hair and scalp, and avoid caffeine, avoid stimulants. They should not get a good night's sleep the night before. They should, I said no stimulants, and warn them that they're going to use flashing lights, and she may have to hyperventilate to produce a respiratory alkalosis, which may induce seizures. So that's basically what they're doing with that. All right, terms, I talked about that important. I'm just going to point out what students get mixed up on. Ipsilateral means the same side. So if you have a head bleed and you have a dilated pupil, it's on the ipsilateral side. Weakness is going to be on the opposite or contralateral side. Okay? Hemiparesis means weakness. Hemiplegia means weakness. Hemiparesis means paralyzed, but they are often used interchangeably. Aphasia means they're having trouble communicating. Dysphagia means trouble swallowing. No, dysphagia means trouble swallowing. Dysphagia means trouble talking or understanding communication. Nystagmus we talked about. We talked about flexor or extensor posturing. Tetraplegia or quadriplegia we'll talk about, but it means the same thing. It's the same term.